In my previous class, I have discussed the epidemiology, incidence, prevalence, etiopathogenesis, and the main culprit of coronary atherosclerosis, as well as the risk factor associated with coronary atherosclerosis and the basic event of stable angina pectoris. Today's discussion is an extension of stable angina pectoris or ischemic heart disease, that is ACS, acute coronary syndrome. ACS এই তিনটে শব্দের মধ্যে A that means abnormal ECG, C means clinical context or scenario, and S means stability, hemodynamic stability, electrical stability, and mechanical stability. What is ACS? অর্থাৎ acute coronary syndrome. ACS has several subcategories like ST segment elevation, myocardial infarction, non-ST segment elevation, myocardial infarction, and unstable angina. আস্তে আস্তে আমি প্রত্যেকটা পয়েন্ট ক্লারিফাই করছি। What is the definition of ACS? That means acute coronary syndrome. Acute coronary syndrome encompasses a spectrum of conditions that include presentation with number one, recent changes in clinical symptoms or signs related to ischemic disease or stable angina pectoris. Number two, with or without changes in 12-lead electrocardiogram or ECG. Number three, with or without elevation of cardiac biomarkers in the form of cardiac troponin concentration or CPK, CBK enzymes or isoenzymes. So, acute coronary syndrome encompasses a spectrum of clinical scenarios that include presentation with recent changes in clinical symptoms and signs in the setting of stable angina pectoris, with or without changes on 12-lead ECG, and with or without acute elevation in cardiac troponin, that is CTN concentration. ACS is eventually categorized into three forms. Number one, unstable angina. Number two, acute myocardial infarction. Again, acute myocardial infarction can be subdivided into two categories. One, non-ST segment elevation myocardial infarction. Another, ST segment elevation myocardial infarction. Diagnosis of AMI, that is acute myocardial infarction, is related to liberation of cardiac troponin release from the cardiomyocytes that reflect an injury or damage or cardiomyocyte necrosis that liberates cardiac troponin. So, liberation of cardiac troponin from cardiac myocytes leading to cardiomyocyte injury or necrosis leads to myocardial infarction or acute AMI, that is acute myocardial infarction. Unstable angina, on the other hand, is defined as myocardial ischemia at rest or on minimal exertion but without any evidence of acute cardiomyocyte injury or necrosis, that is without elevation of cardiac troponin level or concentration. So unstable angina is characterized by absence of cardiomyocyte injury or damage and without any release of cardiac troponin concentration. On the other hand, myocardial infarction, either non-ST segment elevation, myocardial infarction, or ST segment elevation myocardial infarction, is associated with acute changes in cardiac troponin concentration. So, what is unstable angina? Characterized of unstable angina, that is ischemic disease without acute cardiomyocyte injury or damage, is characterized by long-standing angina pectoris at rest with a duration exceeding 20 minutes. Secondly, new onset of severe angina. Third, angina that is increasing in frequency, longer in duration, and at lower threshold. And lastly, angina that occurs after an episode of acute myocardial infarction. Again, I repeat, features of unstable angina, long-standing, prolonged angina pectoris with a duration exceeding 20 minutes at rest. Number 2, new onset of severe angina pectoris. Number 3, angina that is increasing in frequency, longer in duration, or lower in threshold. And lastly, angina that occurs following an episode of acute myocardial infarction. So, acute coronary syndrome, it consists of myocardial infarction, ST segment elevation, ST segment elevation, myocardial infarction, STEMI, or non-ST segment elevation, myocardial infarction, NSTEMI. Symptoms occurs at rest, evidence of myocardial necrosis, increased cardiac troponin or creatinine kinase MB isoenzyme, that is CPK enzyme. Unstable angina, new onset or rapidly worsening angina, crescendo angina, angina on minimal exertion, or angina at rest in the absence of myocardial damage. Now, myocardial infarction has 5 subsets. Number 1, M1, myocardial infarction 1, that is myocardial infarction due to atherothrombotic occlusion of coronary arterial disease, arteries, especially the epicardial coronary arteries. This is the M1. M2, this is a reflection of the imbalance between the supply and demand, that is anemia, thyrotoxicosis, hypertension or hypotension or coronary arterial spasm or coronary embolism. So coronary embolism, coronary arterial spasm, anemia, arrhythmia, as well as hypotension or hypertension constitute type 2 myocardial infarction, that is M2. M3, myocardial infarction during PCI, that is percutaneous coronary intervention. Number 4A, myocardial infarction in stent thrombosis, recent infarction cello, PCI, এবং করোনারি স্টেন্ট ইমপ্লান্টেশন হয়েছে, তারপর যদি সুপার ইম্পোজ থ্রম্বোসিস থাকে, দিস ইজ দ্য মায়োকার্ডিয়াল ইনফার্কশন স্টেজ 4, and stage 5 myocardial infarction following CABG, coronary arterial bypass graft. So myocardial infarction can be subcategorized. M1, it is the occlusive disease of the epicardial coronary arteries. M2, imbalance between supply and demand. And 3, stent, 3, myocardial infarction in sudden cardiac death. 4A, myocardial infarction during PCI. 4B, myocardial infarction during stent thrombosis. And 5, myocardial infarction following CABG. 1, 2, 3, 4, 5, M1, M2, M3, M4, M5. Presentation. Acute coronary syndrome are associated with a wide range of clinical presentation. Number 1, symptom-free at presentation. Number 2, with ongoing chest pain or symptoms. Number 3, with cardiac arrest. Number 4, electrical or hemodynamic instability or cardiogenic shock. So presentation of acute coronary syndrome encompass a wide range of presentation. 1, symptom-free at presentation. 2nd, ongoing chest pain or symptoms. 3rd, cardiac arrest. 4, electrical or hemodynamic instability or cardiogenic shock. This is the ACS spectrum. Clinical presentation: oligo or asymptomatic, increasing chest pain or symptoms, persistent chest pain or symptoms, cardiogenic shock and acute cardiac failure, and cardiac arrest. This is the clinical presentation. Oligo or asymptomatic, increasing chest pain or symptoms, persistent chest pain or symptoms, cardiogenic shock and or acute heart failure, and cardiac arrest. ECG changes that may be normal: ST segment depression, ST segment elevation, and malignant arrhythmias. The working diagnosis is non-ST segment elevation ACS, normal and ST segment depression, and ST segment elevation or malignant arrhythmia, it is ST segment elevation MI. High sensitivity cardiac troponin concentration, non-elevated, that is non-ST segment elevation, acute coronary syndrome. Elevated, that means elevation with or without rise and fall, that is ST segment elevation, myocardial infarction. And final diagnosis: unstable angina, non-ST segment elevation or ST segment elevation MI. এগুলো জানার দরকার নেই, তবু ছোট্ট করে বলে রাখছি। FMC, খুব কমন টার্মিনোলজি, ফার্স্ট মেডিকেল কন্ট্যাক্ট, onset of symptoms and contact with the physician. This is the first medical contact. STEMI diagnosis, already discussed. Primary PCI, that means emergency angiography with an intent to invasive strategy like PCI or CABG according to the coronary anatomy. Primary PCI strategy, emergency coronary Emergency coronary angiography and PCI of the IRAF indicated rescue PCI in case of failed thrombolysis, fibrinolysis or thrombolysis failed. Failure indication key less than 50% resolution of ST segment elevation. Presence or absence of ongoing ischemic symptoms. This is the criteria for failed thrombolysis. And routine early PCI strategy, coronary angiography with PCI on the IRAF indicated within 2 hours and 24 hours after successful fibrinolysis. আগেরটা ছিল failed fibrinolysis অর্থাৎ no relief of chest pain, no normalization of the ST segment constitute the criteria of failed thrombolysis, and successful thrombolysis is the routine early PCI strategy. And pharmaco-invasive strategy, fibrinolysis plus coronary angiography plus PCI. Immediate invasive strategy depending on the patient's clinical scenario like hemodynamic instability or cardiogenic shock or much more fatal cardiac catastrophe. And selective invasive strategy, that means indoor patient, stable patient, non-responsive to conservative or guideline-directed medical therapy may undergo coronary angiography for reperfusion or mechanical revascularization. ACS encompasses a spectrum. First, think ACS at initial presentation. First, think ACS. A. Abnormal ECG. C. Clinical context or scenario. A. That means stability, clinical, hemodynamic or mechanical. Then think invasive management, that means either primary PCI or fibrinolysis or combination of these two, that depends on the duration between first medical contact and the PCI availability or PCI non-availability in the center. Then think antithrombotic therapy, usually aspirin, fasudrel or ticagrelor, or intravenous in the form of iftafibatide or intravenous tiodofiban, or after thrombolysis or after PCI, dabigatran or rivaroxaban. Then think revascularization. Revascularization means PCI or CABG according to the degree of coronary arterial involvement and the anatomic suitability of the coronary arteries. And lastly, think secondary prevention, control of the risk factor, optimization of the lifestyle, adaptation of an optimum exercise program, and others. Diagnosis. Clinical presentation. Symptoms and signs suggestive of ischemic heart disease. Perform an ECG within 10 minutes of FMC, first medical contact. সেখান থেকে দুটো অপশন আসতে পারে ওয়ার্কিং ডায়াগনোসিসে, STEMI or non-STEMI. Then go for cardiac biomarker, elevation or angiography or imaging, and the final diagnosis is STEMI, non-STEMI, unstable angina or non-ACS, অর্থাৎ কার্ডিয়াক ডিজিজই নেই। ইনিশিয়াল ম্যানেজমেন্ট, ইসিজি ফার্স্ট হচ্ছে ACS প্রেজেন্টেশন, ইনিশিয়াল ACS অ্যাসেসমেন্টের রাস্তা হচ্ছে ইসিজি, clinical presentation or physical examination, clinical history, vital signs, and cardiac biomarkers. Working diagnosis, already told, then early invasive strategy, either PCI, antithrombotic therapy, or fibrinolysis, or combination of these. But PCI and ATT, antithrombotic therapy. Non-ST segment elevation ACS, PCI, and antithrombotic therapy. Non-ST segment elevation does not constitute any indication for fibrinolysis or thrombolysis. So deliberately I have missed fibrinolysis. STEMI option, PCI, ATT, and fibrinolysis. But non-ST segment elevation, PCI, and antithrombotic therapy, no fibrinolysis, and non-STE ACS এক্ষেত্রে consider the risk factor associated with non-ST acute myocardial infarction. High risk subject may undergo reperfusion therapy, particularly mechanical reperfusion therapy in the form of PCI or CABG, and অবশ্যই ATT. যে পয়েন্ট খুব ইম্পর্টেন্ট, non-ST segment elevation never constitute any indication for fibrinolysis or fibrinolytic therapy. Further investigations, non-immediate angiography, echocardiography, cardiac imaging like cardiac CT, or non-imaging like stress test for adaptation of the exercise capacity, and the cardiac biomarkers for assessment of prognosis, as well as ECG monitoring. For the management, again there may be repeat PCI, CABG, long-term medical therapy, lifestyle modification, smoking cessation. এটা বলা হয়ে গেছে, ছেড়ে দিচ্ছি। Non-ST segment elevation without or acute coronary syndrome without elevation of the cardiac biomarkers. এটাই শেষ কথা না, এক্ষেত্রে রুল ইন, রুল আউট অ্যান্ড অবজারভেশন তিনটে পলিসি মেনটেন করা উচিত। অর্থাৎ অ্যাট প্রেজেন্টেশন কার্ডিয়াক ট্রোপোনিন কনসেন্ট্রেশন অ্যাসেসমেন্ট করে নেব, তারপর অ্যাট 1 আওয়ার, অ্যাট 2 আওয়ার কার্ডিয়াক ট্রোপোনিন কনসেন্ট্রেশন অ্যাসেস করার দরকার পড়বে। যদি দেখা যায় সেকেন্ড অ্যাসেসমেন্ট অর্থাৎ অ্যাট 1 or 2 আওয়ার কার্ডিয়াক ট্রোপোনিন কনসেন্ট্রেশনের বিশেষ কিছু চেঞ্জ নেই, তাহলে রুল আউট পাথওয়ে, অর্থাৎ নন এসটি সেগমেন্ট এলিভেশন অ্যাকুট করোনারি সিনড্রোম বাদ পড়ে থাকলো আনস্টেবল অ্যাঞ্জাইনা। উল্টোটা, যদি দেখা যায় লেভেল হাই অর ফ্ল্যাকচুয়েটিং, তাহলে এটাকে ইনক্লুড করে নেব। দ্যাট ইজ রুল ইন phenomenon or rule in pathway that would be treated in the line of acute coronary syndrome. And the equivocal result, we should observe the pathway with assessment of the clinical parameters as well as the electrocardiographic assessment. So rule in pathway, rule out pathway, and observation pathway যেখানে controversial or equivocal cardiac biomarker or CTN concentration. Non-ST segment elevation a scoring system known as TIMI score age less than, sorry, age equal to or greater than 65 years. Non-coronary artery disease, 50% or more coronary arterial stenosis. East segment deviation more than 0.5 millimeter on surface ECG. Enhancement of the known coronary artery disease with 50% or more coronary arterial stenosis. ST segment deviation more than 0.5 millimeter on surface ECG. Enhancement of the cardiac biomarkers, two or more original episodes in the previous 24 hours, and prior angina pectoris, three or more coronary artery risk factors গুলো কিন্তু আগে পড়ানো হয়েছে। Repeat: age, known coronary artery disease, ST segment deviation, cardiac biomarkers, more or two original episodes, prior angina, and three or more coronary arterial disease risk factors. Again, a score, GRACE score. GRACE score means Global Registry of Acute Coronary Events score. That is on the basis of age, findings at initial presentation, findings during hospitalization, history of CHF or history of congestive heart failure, history of MI, systolic BP, elevated cardiac enzymes, ST segment depression, lastly, non-availability of PCI, age, initial presentation, hospitalization scenario, history of congestive heart failure, history of MI, systolic BP, and elevated cardiac enzymes, ST segment depression, lastly, non-availability of PCI. Each and every points are added to summarize a score exceeding 140, a risk factor for non-ST segment elevation acute coronary syndrome that may need aggressive therapy for management. There are 5 types of MI. আগেই বলেছি, আবার একটু সামারি করে দিচ্ছি। Type 1, spontaneous MI with ischemia due to a primary coronary event, plaque erosion, rupture, fissuring, or ulceration. Type 2, MI secondary to ischemia due to increased oxygen demand or decreased supply, coronary spasm, coronary embolism, anemia, arrhythmia, hypotension or hypertension. Type 3, diagnosis of MI in sudden cardiac death. 4A, MI related to PCI. 4B, MI related to stent thrombosis. And 5, MI related to CABG. History taking. It is crucial to take a focused medical history and accurately characterize the presenting symptoms in an attempt to formulate a therapeutic strategy, either in the form of pharmacotherapy or reperfusion, either mechanical or pharmacological. Prompt assessment of vital signs is recommended at first medical contact, that is FMC. At the same time, acquisition of an initial ECG. And focused physical exam include major pulses, BP with both arms, auscultation of heart and lungs, and assessing for signs of heart failure or shock. এগুলো বারবার বলা হয়েছে, আমি প্রায় শতাব্দী প্রাচীন যুগ থেকে কথাগুলো বলে আসছি। Now, ST segment elevation acute coronary syndrome criteria. What is ST segment elevation? New ST segment elevation at the J point in at least two adjacent or contiguous leads, 2.5 millimeter or more in men in less than 40 years, or 2 or more millimeter in male more than 40 years, or 1.5 or more in women irrespective of age. Repeat. 2.5 or more ST segment elevation in male less than 40 years. 2 or more in male more than 40 years. And 1.5 or more in females irrespective of age. মেয়েদের ক্ষেত্রে অল্প এলিভেশন হলেই ইন্ডিকেশন অফ এসটি সেগমেন্ট এলিভেশন ACS, and or 1 or more millimeter in the other leads in absence of left bundle branch block or left ventricular hypertrophy. Show ST segment elevation, acute coronary syndrome, new onset ST segment elevation at the J point in at least two contiguous leads, 2.5 or more, less than 40, 2 or more than 40, and 1.5 or more in women irrespective of age, plus and or 1 or more millimeter in other leads in absence of LVH or LBB. Acute coronary syndrome without persistent ST segment elevation অর্থাৎ নন ST segment elevation, এটা বুঝবো কি করে? While the ECG in the setting of non-ST segment elevation may be normal in more than 1/3 cases of non-ST segment elevation ACS, but certain changes may reflect or may produce a suspicion like ST segment depression and T-wave changes, especially biphasic T-waves or prominent negative T-waves, that is Whelan's sign, as well as flat T-wave inversion. Therapy, acute pharmacotherapy. First, oxygen. Oxygen supplementation is essential in presence of hypoxemia. That means arterial oxygen saturation less than equal to 90%. In a setting of arterial oxygen saturation more than 90%, no oxygen supplementation is necessary. It may be detrimental. So oxygen saturation is an essential criteria for oxygen supplementation. Second, nitrates. Nitrates may relieve chest pain. First, sublingual nitrate in a dose of 0.3 to 0.6 millimeter at an interval of 5 minutes with a maximum dose of 3. It should be contraindicated in severe hypotension, marked bradycardia, or marked tachycardia, right ventricular infarction. And taking or history of phosphodiesterase 5 inhibitor within the previous 24 to 48 hours. Sildenafil 24, tadalafil 48 hours. Pain relief, intravenous opiates. তার আগে একটা কথা বলে রাখা ভালো, 3টে নাইট্রোগ্লিসারিন অ্যাডমিনিস্টার করার পর যদি দেখা যায় নর্মালাইজেশন অফ এসটি সেগমেন্ট এলিভেশন হচ্ছে না, প্লাস রিলিফ অফ অনগোয়িং চেস্ট পেন রিলিফ হচ্ছে না, সেক্ষেত্রে ইন্টারভেনাস নাইট্রোগ্লিসারিনে যেতে পারি। ডোজ হচ্ছে 5 to 10 মিউজি stat followed by 5 to 10 mg per hour, and that may be increased at an interval of 5 to 15 minutes by 10 mg per minute till relief of pain or development of hypotension. Pain relief, intravenous morphine. Morphine reduces pain. Morphine beneficial impact: number one, relief of mental anxiety by sedation, relief of cardiac anxiety by reduction of the preload by means of vasodilatation, relief of cardiac myocardial oxygen demand by negative inotropic and chronotropic effect. But it has two side effects: nausea, vomiting, and gastrointestinal delay that may delay the reabsorption of orally administered drugs. Intravenous beta blocker. Beta blocker reduces cardiac contractility, reduces cardiac output, and reduces myocardial oxygen demand. Initially, intravenous beta blocker, metoprolol usually used in the dose of 5 milligram at an interval of 5 to 10 minutes. Maximum 3 doses are administered. After the last dose of intravenous beta blocker, after 15 minutes, oral beta blocker in the form of metoprolol 50 milligram 6 hourly for 48 hours, then 100 milligram twice a day for the rest of the time, or the hospital stay, or even longer. Activity. During acute phase, the patient should be placed at bed rest, and depending on the clinical situation, gradual ambulation is advocated in order to relieve the mental anxiety and sense of well-being. Diet should be nothing for initial 8 to 12 hours because of associated nausea and vomiting, then gradually liquid, semi-solid, solid with low cholesterol content diet should be prescribed. Bowel management, stool softener, constipation increases the myocardial workload and stress, so stool softener in the form of PT should be added in the therapy. And lastly, tranquilizer. A patient presenting with acute myocardial infarction is in an anxious state, so adequate sedation is recommended, either diazepam or alprazolam twice or thrice a day, and an additional dose at the bedtime for better sleep is essential or a necessity in the overall management of acute myocardial infarction. ACE inhibitor. To minimize the hemodynamic consequences and the prevention of remodeling, ACE inhibitor is an adjunct therapy to the management of acute myocardial infarction. Thrombolysis. যেখানে PCI facilities is not available, within 120 minutes, সেক্ষেত্রে আমরা ফিব্রিনোলাইসিস থেরাপিতে যাওয়ার চেষ্টা করি উইদিন 30 মিনিটস। ফিব্রিনোলাইসিসের মধ্যে আমরা ইউজ করি টিস্যু প্লাজমিনোজেন অ্যাক্টিভেটর or streptokinase or টেগনিপ্লাজ। মেনলি আমাদের সেটিংয়ে ইউজ করা হয় স্ট্রেপ্টোকাইনেজ। ডোজ ইজ ইউজুয়ালি 1.5 million units over 1 hour, or tissue plasminogen activator 15 minutes, 15 milligram stat followed by 50 milligram after 30 minutes, and then the next 35 milligram in the next 60 minutes. এত সব লেখা আছে কিনা আমি জানি না, বলে গেল। Contraindications: history of cerebrovascular hemorrhage at any time, non-ischemic hemorrhagic stroke or other cerebrovascular event within the past year, severe hypertension, systolic BP more than 180 or diastolic BP more than 110, and suspicion of aortic dissection or active internal bleeding. Relative contraindications: that means current use of anticoagulation therapy with INR exceeding 2 or more, recent invasive or surgical procedure within previous 2 weeks, bleeding diathesis, or long CPR, that is cardiopulmonary resuscitation, more than 10 minutes, peptic ulcer disease, and previous history of severe hypertension not controlled with current medication. Invasive strategy and reperfusion therapy. Working diagnosis of STEMI, immediate reperfusion, that is a PCI, percutaneous coronary intervention strategy, or fibrinolysis if PCI is not available, or working diagnosis of non-STE ACS, an inpatient invasive strategy, that is 2-hour to 24-hour coronary angiography, and depending on the coronary anatomy, either invasive strategy or pharmacotherapy. An immediate invasive strategy are very high risk are present. An early invasive strategy that is within 24 hours, but high risk. So, তিনটে category: one inpatient invasive, second immediate invasive, and third early invasive. Immediate invasive or non-ST segment elevation. An immediate invasive strategy refers to emergency, so as soon as possible angiography and PCI. Example: high risk, very high risk, hemodynamic instability or cardiogenic shock, recurrent or ongoing chest pain refractory to medical treatment, acute heart failure presumed secondary to ongoing myocardial ischemia, life-threatening arrhythmia or cardiac arrest after presentation, mechanical complications, recurrent dynamic ECG changes suggestive of ischemia, particularly with intermittent ST segment elevation. Very high immediate invasive strategy with PCI. Early invasive strategy, there is a high risk, not very high. A confirmed diagnosis of non-STEMI based on current recommended ESC high sensitivity cardiac troponin algorithm, dynamic ST segment change or TF change, transient ST segment elevation, and a gray score 140. Gray score means age, presentation at FMC, presentation at hospital scenario, presence of heart failure, presence of MI, presence of the elevation of cardiac biomarkers and non-availability of the PCI. All these constitute the gray score more than 140. It is categorized in the high risk, not very high risk. This is the schematic representation. First medical contact. Symptoms of ACS and ECG consistent with non-ST segment elevation. Very high. Hemodynamic instability or cardiogenic shock, recurrent or ongoing chest pain, acute heart failure, life-threatening arrhythmia, mechanical complications, recurrent dynamic ECG change. High. Confirmed diagnosis, gray score, transient ST segment elevation, and dynamic ST change, and risk stratification, and that determine the therapeutic strategy. Primary risk factor. এটা পড়া হয়ে গেছে, বলার দরকার নেই। Antithrombotic therapy. Antithrombotic therapy is an essential in the management of acute coronary syndrome. Usually, most commonly used antithrombotic therapy is aspirin. Loading dose 165 to 325, or clopidogrel. Loading dose 300 to 600 milligram, or in a setting of PCI, ticagrelor or pasugrel. Ticagrelor dose 180 milligram stat followed by 90 milligram twice a day. Pasugrel 60 milligram stat followed by 10 milligram per day. And anticoagulation, commonly drugs are unfractionated heparin, low molecular weight heparin, and fondaparinux. Unfractionated heparin, usual dose 10 to 15 milligram, 15 unit per kg per hour. Fondaparinux dose 2.5 milligram subcut once a day, or enoxaparin dose 1 milligram per kg twice a day. ডিটেলসে যাচ্ছি না, টাইম নেই। অ্যান্টিপ্লেটলেট, clopidogrel, aspirin, pasugrel, ticagrelor. Anticoagulant, heparin, low molecular weight heparin, fondaparinux, and rivaroxaban. এটা হচ্ছে মায়োকার্ডিয়াম, এটা এনার্জি কনজাম্পশন দরকার নেই, এগুলো অ্যানালিসিসের দরকার নেই, এগুলো বলা হয়ে গেছে, প্লাগফুল দরকার নেই, ছেড়ে দিচ্ছি। লং টার্ম, smoking cessation, number 1, lifestyle accommodation, number 2, exercise program, number 3, and the control of the risk factor, number 3, and associated pharmacotherapy, number 4. Short form আসছি। Aspirin 75 milligram daily, clopidogrel oral beta blocker proton pump inhibitor, ACEI, high intensity statin, that is LDL cholesterol concentration should be kept under 55 milligram percent by means of atorvastatin 80 milligram or rosuvastatin 40 milligram with or without azacitidine. Aldosterone antagonist, if there is clinical evidence of the heart failure, patients with premature permanent atrial fibrillation receiving mechanical therapy, etc., etc. And lastly, complications. Hemodynamic consequences. Hemodynamic subset 1. অর্থাৎ no evidence of heart failure or hemodynamic compromise. Subset 2. Mild heart failure evidenced by venous or arterial congestion and basal creps not exceeding half of the lung fills. And subset 3, basal creps exceeds the half of the lung fills. And 4, that is cardiogenic shock. This is the clip classification. Clip 1, no evidence of heart failure. 2, mild evidence of the heart failure. 3, basal creps not exceeding half of the lung fills or more than 10 centimeter, and more than half of the lung fills, stage 3, and stage 4, there is cardiogenic shock. Forrester et al. Classification. Stage 1, no hemodynamic consequences, that is PCWP less than 18, cardiac index more than 2.2. Second, pulmonary congestion, no evidence of hypoperfusion, PCWP more than 80, cardiac index more than 2.2. Third, no pulmonary congestion but low cardiac output, PCWP less than 18 millimeter of mercury, cardiac index more less than 2.2. And lastly, cardiogenic shock, pulmonary venous congestion, that is PCWP, more than 18 millimeter of mercury, and cardiac index less than 2.2. That's all.